Hello, everyone. My name is Brett Conliff, and I'm going to be talking about prostate cancer. I'll ask you to bear with me as my voice has decided to disappear, so my Starbucks tea and water are going to hopefully get me through this. If you can't hear me, just wave, and I'll try to talk louder. But I currently am a clinical pharmacist at the Brown Cancer Center in Louisville, Kentucky. Up until recently, I was our GU pharmacist. I've just transitioned out of that, so for now I think I still know what I'm talking about, but this will be my last time doing this talk as I've moved on to other things. I don't have any disclosures to let you know about. These are our objectives for today, so primarily talking about treatment, supportive care, and monitoring while taking into account the guidelines in primary literature, goals of therapy, and then briefly we'll talk about guidance for public related to prostate cancer screening and prevention. So that brings us to our first audience response question. DR is a 40-year-old Caucasian male with a past medical history of seasonal allergies. His PCP checked a PSA, which resulted at 9, and he had an abnormal digital rectal exam. Further imaging and biopsy revealed a very low-risk prostate adenocarcinoma. He prefers a treatment strategy that minimizes adverse effects. Which of the following is most appropriate for him at this time? Is it active surveillance, radical prostatectomy with ADT for the short term, or radiation therapy with short-term ADT, or observation? And most of you got this one correct. So the correct answer is active surveillance. We'll talk about the differences in observation and active surveillance on the next slide. So localized prostate cancer, the world's kind of your oyster. You have a lot of options for how to manage. 2 of those options are observation and active surveillance. At first glance, they sound very similar, but there are actually some differences that are important to note, and the main being what the goal of care is. So with observation, this is for patients who are older, have a shorter life expectancy, and their goal is just to avoid symptoms. So you're going to delay treatment as long as possible until symptoms have occurred or are imminent, and then you treat with palliative therapy. With active surveillance, this is for our younger patients who want to delay side effects of treatment as long as possible, but still want curative intent therapy. So you're going to monitor them closely and intervene when their disease starts behaving more aggressively. So you're still going to attempt to cure them, you're just waiting to start the curative treatment until later. Our local therapies that are curative for prostate cancer are either radical prostatectomy with or without a lymph node dissection, or radiation. Excuse me. Radiation can either be with external beam therapy or brachytherapy. And then you have the option of adding ADT in the adjuvant setting to either to radiation therapy. Not studied with surgery, only with radiation. And your options for ADT are either surgical or medical castration. This means we're trying to get their testosterone to a level below 50. So that's the definition of castration. Levels of testosterone is less than 50. You can either accomplish this with surgical castration with the bilateral orchiectomy, or with medical castration with either an LHRH agonist or antagonist. Excuse me. The different medical options for ADT are discussed in detail in the handout, and we won't really be going into that today, but refer to your handout for that information on pharmacology and dosing options. Briefly, I'll talk about the different options for prostate cancer. This all comes from the NCCN guidelines, and I only include it just to show that there are a lot of different options that are appropriate on how to manage these patients. And again, it depends on their expected survival as well as their recurrence risks. So they're grouped into a recurrence risk from very low all the way up to high. And then you also look at their expected survival. When survival is low and their risk is low, your mainstay of treatment is observation, versus if their expected survival is longer, it's active surveillance. But as the risk increases, your modalities of treatment become more important. So you're going to do an intervention more as you get to intermediate, into high and very high. And so once you get into high or very high, ADT is almost always involved in some form, whether it's adjuvant or continuously. Sorry. Adjuvant ADT has been, as I mentioned earlier, added to radiation therapy. In the short term, that's shown a benefit for intermediate disease, and long term, meaning 2 to 3 years, has shown a benefit in high-risk disease. And in my practice, this is mainly where we use it, is that 2 to 3 years for high-risk disease. The addition of ADT to surgery without radiation being involved has not shown a consistent improvement in survival. If you have surgery and radiation, then it makes sense to add adjuvant ADT, but just surgery alone, a benefit of adding adjuvant ADT has not been demonstrated. And that brings us to the bulk of our talk today, which will be the advanced, recurrent, and metastatic setting. I think prostate cancer nomenclature gets pretty confusing. It's different from other cancers where we don't just talk about curative intent versus metastatic palliative intent. We also add in this whole concept of castrate sensitive versus castrate resistant, which used to make a lot of sense when your first line treatment was just ADT, and then when they progressed on that, they were castrate resistant. Well, now we've really complicated everything by changing how we treat our castrate sensitive patients, and we'll talk a lot about that later. But to try to simplify things, I like to break down prostate cancer into 3 buckets, and we'll talk through each bucket one at a time. And I break them up into whether they have metastatic disease or not, and to whether they have castration-sensitive or castrate-resistant disease. So the bottom of each bucket has your abbreviation. So M0 is non-metastatic, CS is castrate-sensitive, and then prostate cancer. So the first group we'll talk about is that non-metastatic castrate-sensitive disease. And that brings us to our next audience response question. LB is a 40-year-old male with a history of myocardial infarction 3 months ago. He has low-risk prostate cancer treated with external beam radiation 6 months ago. He follows with his oncologist regularly, and his PSA has doubled in the last 4 months. He presents today to discuss recent imaging, which shows no sites of metastatic disease. He's not a candidate for further local therapy and is hesitant to pursue ADT because he fears the adverse cardiac events. Which of the following is most appropriate for him? Continuous ADT with leuprolide, intermittent ADT with relugolix, intermittent ADT with leuprolide, or no role for ADT at this time. Okay, so yes, intermittent ADT is a good option for him. We'll talk about why, but actually I think relugolix is the preferred option for him with his cardiac history. But yes, you're correct, he did need ADT, and intermittent is a good choice since he wants to limit toxicities. So biochemical recurrence, the definition would be increasing PSA with no metastatic disease, but local options have been exhausted. So no pelvic therapy option remains, either surgery or radiation. Your choices are either ADT or just observing the patient, and which you choose depends on how aggressive their disease is behaving, so their PSA velocity and doubling time, as well as their life expectancy. In this setting, it's reasonable to just observe them if they have a short life expectancy, but their biology of their cancer is slow growing. The concept of intermittent ADT is an option throughout, but really the place where we mainly use it is in biochemical recurrence. And what this is you start ADT whenever their PSA rises above some predefined level. The ADT brings their PSA down to some predefined level, and then you can stop it once it reaches that level. And then when it starts coming back up again, you restart the ADT. Those levels, PSA levels, vary depending on what reference you're looking at and what pelvic therapy they had to begin with, whether surgery or radiation. The pitfalls of this option is it requires very close monitoring during their treatment break, and they may end up being on therapy more often than they're off of it. but you could potentially decrease adverse effects and costs. So it's controversial whether to use it with metastatic disease, but it's definitely an option in biochemical recurrence. Relugolix is not really a new drug, but I keep it in the slides because I don't think it's been really used a lot. Raise your hand if you've used Relugolix. Yeah, so it's not, I don't think it's taken over as our ADT of choice, but it may as we get more information about it. So I like to keep it in the slides for now anyway. So this is an oral GnRH antagonist, meaning it has a quick onset of action to decrease testosterone, no tumor flare risk. It is dosed orally, daily, 3 tablets on the first day as a loading dose, and then once a day thereafter. If you miss more than 7 days, you're supposed to reload. It has side effects similar to our other ADT drugs, but adds QTc prolongation and diarrhea. It does have some drug interactions, and it's a major substrate of PGP, which I'll talk about more on the next slide, or in a couple slides. Some pearls. And get out your pens, because we're going to make a change, because the NCCN updated their guidelines 2 or 3 days ago. Of course, they always update right before I give a talk on prostate cancer. So this first pearl about not being used in combination, you can cross that out. The NCCN changed their wording to just remove anything that said you shouldn't use it in combination, and made their guidelines more general, where they just say use a GnRH antagonist rather than listing specific drugs. And I do have a study that kind of supports that coming up in a couple slides. But another pearl that you should note is that adherence was more than 99% in the trial, which probably doesn't reflect the real world. So it's something to keep in mind when selecting patients for this treatment option. And you should consider testosterone monitoring to ensure that they're compliant and that it's effective in maintaining castrate levels of testosterone. The HERO trial is the study that got Relugolix approved. And this was for patients with first-line castrate-sensitive disease or with advanced local disease or biochemical recurrence. They were randomized 2-to-1 to Relugolix with the dosing I previously discussed, or Leuprolide. Their primary endpoints all kind of demonstrated the mechanism of action of the drug. There weren't really any efficacy endpoints like survival or progression-free survival. They looked at the levels of, or the rates of sustained castrate levels of testosterone through 48 weeks, which Relugolix was superior, but hasn't shown superiority in survival or any other endpoint like that. It did show that it has a faster onset of action, so castrate levels at day 4 favored Relugolix, which makes sense based on its mechanism of action. Testosterone also recovered more quickly once the drug was stopped, which also makes sense based on its mechanism of action as a daily oral drug versus an every 3-month injection. One thing to note is that the cardiovascular events were lower with Relugolix, and I talk about this a lot in the handout, but with GnRH antagonists in general, we've seen lower incidence of adverse effects, cardiac adverse effects, compared to our GnRH agonists like Leuprolide. So this was not a surprise, but it was nice that there was a difference seen, because this was an exploratory endpoint and not a defined endpoint of the trial. That's not really included in the package insert. But it is something to note that the cardiovascular adverse events were lower, and that is sometimes a reason why I choose this drug for patients. So as promised, the drug interactions, PGP is the most important enzyme for Relugolix bioavailability. Other drugs that we use in prostate cancer in combination with our ADT can affect PGP. Specifically, enzalutamide can be an inducer or an inhibitor. So we have to use caution in just adding these drugs together on patients where it hasn't been studied. In the HERO trial, if patients began progressing on their ADT alone, they were allowed to add on either docetaxel or enzalutamide. This publication that came out last year was the first data we had on patients on those combinations of drugs, and it's very low numbers, 24 patients total, but it's something. 2.7% received combination with enzalutamide and 1.3% with docetaxel. In this study, they showed no difference in castration rates through 48 weeks compared to those that were just on single-agent ADT. Again, only 24 patients. But they did look at actual testosterone levels in your relugolix versus relugolix plus enzalutamide, and it was 10 versus 15, so numerically a difference, but probably not clinically significant since it's well below that 50 level that we shoot for castration levels. So this is one thing that makes me feel better about using it in combination, and I think probably also led the NCCN to update their guidelines. And there is an ongoing trial that will give us more data on this that's comparing different combinations of therapy. Another new study that just came out in the last year for this setting of biochemical recurrence is enzalutamide. So the EMBARK trial was a phase 3 trial that looked at high-risk biochemical recurrence patients, and how they defined high risk is in this black box on the slides, but essentially a fast doubling time, and they never reached a nadir that the study defined as being a good nadir, depending on whether they had surgery or radiation. So that's a poor prognostic factor if you don't have a low nadir after your initial pelvic therapy. And they couldn't be a candidate for any other salvage radiation at the time of their recurrence. They were randomized to one of 3 arms, which were leuprolide plus enzalutamide, leuprolide plus placebo, or enzalutamide alone. So this is our first FDA approval for enzalutamide alone. So this is the big deal, that they studied enzalutamide without any ADT backbone. This is the first time we'll be using that. Another interesting point about this study is they were kind of looking at the concept of intermittent ADT. So at 36 weeks after starting the trial, patients had a PSA check. If it was less than 0.2, they stopped therapy. If it was more than 0.2, they continued treatment. And I did ask, it's not if they reach these PSA levels at any point, it's only at this one-time check. So if at 40 weeks their PSA is less than 0.2, they don't get to stop therapy according to the trial. So it's only if at this one time point their PSA met that level, they could go off treatment. And then if PSA rose, they would later resume it. And we'll talk about that more on the next slide. So as far as efficacy, they compared their leuprolide plus enzalutamide to leuprolide alone, and their enzalutamide to leuprolide alone, as leuprolide was our previous standard of care, or another ADT was the previous standard of care in this setting. Their 5-year metastasis-free survival, both enzalutamide-containing regimens was favored over leuprolide alone. The same with PSA progression-free survival. And then when you look at overall survival, this endpoint was not mature at the time of publication, but the leuprolide plus enzalutamide was favored over leuprolide alone, and then enzalutamide was not different at this immature reporting compared to leuprolide alone. But based on this data, the FDA approved either option, so enzalutamide plus or minus leuprolide for biochemical recurrence. And as I said, that's the first time enzalutamide alone has been approved, so that's pretty exciting. This treatment suspension option, if they met that level and they stopped their ADT, PSA was rechecked every 3 months and resumed when they met a predefined PSA level. It was interesting to look at how many patients got to stop therapy, and there were more patients that got to stop therapy in your arms that contained enzalutamide, which is interesting. So maybe more treatment up front buys you more time off treatment later. So that's your first column, is the percentage of patients that got to stop their treatment at all. And then the next column is how long that they were able to stay off treatment. The 2 leuprolide-containing arms were able to stay off treatment longer, which makes sense mechanistically or pharmacologically because it's a 3-month shot, whereas your enzalutamide is going to stop having efficacy a few days after you stop your last dose. And the last column is those that were able to stay off treatment for at least 2 years. Higher amounts in your leuprolide-containing arms, which again makes sense. So what I really thought was interesting about the trial was the enzalutamide monotherapy and what kind of side effects are our patients going to have. It's great that the efficacy is there, but this was the first time I'd really delved into the toxicities of enzalutamide alone. Pharmacologically, the effect of enzalutamide on testosterone. So enzalutamide is a receptor antagonist, so it's blocking the binding of testosterone. It doesn't affect your levels of testosterone, whereas leuprolide's decreasing your testosterone levels, of course. So because of the negative feedback loop, your body's going to make more testosterone when you have a receptor antagonist like enzalutamide. So in the enzalutamide alone arm, testosterone levels were supraphysiological, versus the leuprolide arm containing arms, you had castrate levels of testosterone. So what that means for side effects, if we jump to the bottom, gynecomastia and nipple pain were much higher in enzalutamide versus your leuprolide alone arms. So that's definitely something we should counsel people on if they are pursuing this enzalutamide alone arm. It's pretty significant. Almost half of the patients had any grade of gynecomastia. And then also ischemic heart disease was higher with the enzalutamide alone. So something about that higher testosterone can affect cardiac health as well. The other side effects kind of make sense. Your leuprolide-containing arms had a lot more hot flashes. So if hot flashes are your patient's biggest problem, then maybe enzalutamide alone is a better option for them. Your fatigue and CNS issues were higher in your enzalutamide-containing arms, which makes sense. That's a known side effect of enzalutamide. And then seizures were a little higher in the enzalutamide-containing arms, as expected. Patients with seizure history were excluded from the trial. So with that, about 1% incidence of seizures. Okay, so that finishes biochemical recurrence, and now we will talk about non-metastatic castrate-resistant disease. RC is a 59-year-old male that presents to your clinic with a history of node-positive prostate cancer, currently on leuprolide. 6 months prior, his PSA was 2.4. 3 months prior, it was 4.7, and today it's 25. His testosterone is less than 20. CT shows no metastatic disease. What's the most appropriate change in his treatment at this time? Should he stop leuprolide and start docetaxel and prednisone? Stop leuprolide and start relugolix? Continue leuprolide and add darolutamide? Continue leuprolide and add abiraterone and prednisone? Okay. So yes, most of you knew that you shouldn't stop or change your ADT. We do want to add darolutamide. Abiraterone is actually not indicated in this setting, but we'll talk about what drugs are on the next slide. So metastatic castrate-resistant prostate cancer means their PSA is doubling, less than 10 months doubling time, but you've done scans and there is no evidence of metastatic disease, but they've already been on ADT. So that's our difference from the last bucket, is that they've been on ADT, their testosterone's less than 50, and now they're progressing. So in this setting, you have there's 3 second-generation androgen receptor antagonists, and all have an indication in this setting: apalutamide, enzalutamide, and darolutamide. All have shown over time, eventually, with multiple publications, have shown an overall survival benefit. So any are efficacious and appropriate in this setting. So you would just add one of those on to ADT for a patient that met the criteria for non-metastatic castrate-resistant disease. And I just like to use this opportunity where they're all indicated to highlight some differences between the drugs. I think this is an easy place to test because there's some things you can highlight why you might want to use one drug over the other. So enzalutamide and apalutamide are very similar. In my brain, I kind of group them together. Both of them, the dosing is 4 pills once a day. So the actual numerical doses are different, but with the way they're made, it's 4 pills once a day. Both have a lot of drug interactions. They're strong CYP3A4 inducers. So, you're really going to want to look at med lists when you're starting a patient on these drugs, because they could have significant drug interactions. These drugs cross the blood-brain barrier and cause a lot of CNS issues, increase the risk of falls. Fatigue is a major issue. And when you're on ADT, your bone health is probably not great, so if you're falling, you're likely to fracture something, so fracture risk is high in these patients. And they should all be on calcium and vitamin D. In addition, with crossing the blood-brain barrier, they increased seizure risk. So patients with seizure history were excluded from all their phase 3 trials. With apalutamide, you have all of that plus the risk of rash and hypothyroidism. And then we'll contrast that to the newer agent, darolutamide, which doesn't cross the blood-brain barrier and has less drug interactions. Its dosing is 600 milligrams twice a day with food, so twice a day instead of once a day, but it's 2 pills twice a day. And it's only a weak CYP3A4 inducer. So this is the time I pick this drug, is if I have some unavoidable drug interaction and I don't want to deal with that with the other drugs, I pick darolutamide instead. Adverse effects are much more tolerable because it doesn't cross the blood-brain barrier. Patients with seizure history were allowed in the trials, and there was no difference compared to placebo. Fatigue, only 12%, so that's much better than the enzalutamide and apalutamide. You do have to dose adjust for renal and hepatic impairment, which is different than the others, so just something to keep in mind. All right, so that brings us to our next bucket, which is metastatic castrate-sensitive disease. And this is kind of where most of the patients that I see fall. The first 2 buckets aren't quite as common. And when we talk about that, first I'm going to do a very quick history lesson because an interesting study came out last year that I think really highlights the role of the oncology pharmacist and the importance of staying up to date with the literature. So prior to 2015, as I mentioned earlier, the treatment for prostate cancer, metastatic prostate cancer, was put them on ADT. When they progressed, they're castrate resistant, and you just add something to their ADT. It was great. It was simple. Then they made it more complicated. So by 2021, there were 4 drugs studied in combination with ADT up front. When you progressed on that, then you were castrate resistant, and you switched kept your ADT backbone, but switched to something else. Now, not only do we have all of these doublet options, we have triplet options, which we're going to talk a lot about in our next slides. So you can do 3 things up front, and then keep your ADT backbone and switch to something else at progression. I'm sorry. So the study that came out looked at real-world practice and how it compared to prescribing patterns, and if prescribers were consistent with the guidelines. And there were 243 patients, and they had 4 groups based on the time that the patient was diagnosed and initiated treatment. So group 1 was the good old days that I told you about, where you just did ADT. Group 2, group 3, and group 4, whereas those other drugs got approved in combination with ADT up front. And in the chart, you'll see that group 1, 90% of providers were consistent with the guidelines, so that was great. But by the time you get to group 4, only 1/3 of providers are giving patients treatments that are consistent with the guidelines. So that's why it's important to stay up to date on all these changes and try to make sure we're helping our providers stay up to date on the new things that are available and giving our patients the best treatment option, because all of these new updates to the guidelines do improve overall survival. Giving more things up front does improve overall survival for our patients. So AC is a 65-year-old male with a history of hypertension controlled with amlodipine. After initially presenting with back pain, imaging and biopsy revealed prostate cancer metastatic to the liver and spine with the BRCA2 mutation. His performance status is 0. All lab values are within normal limits except for a PSA of 87. In addition to starting ADT, which of the following is the most appropriate treatment option for for AC, sorry, typo, seeing if you're paying attention, for AC at this time? Is it enzalutamide, abiraterone plus olaparib, docetaxel, or docetaxel plus darolutamide? All right. So you were paying attention that BRCA2 was in the question, so I appreciate that, but BRCA2 or PARP inhibitors aren't indicated in the castrate-sensitive setting. We'll get there, but we're not there yet. So our second choice of docetaxel and darolutamide is correct. So a triplet option of ADT, docetaxel, and darolutamide would be most appropriate for this patient. So here's our kind of our goal is that we'll understand all of this by the end. A lot of this is talked about in the handout, and I'm not going to talk about today. What I'm going to focus on is what's new in the last year, and that's our triplet therapies. So the top part of ADT plus one of those three options, refer to your handout. The next little section of ADT plus docetaxel plus either abiraterone or darolutamide, that's what I'm going to focus on today. And this is another place where you're going to get your pen and change so we can match what the NCCN guidelines say now. Prior to this week, NCCN said trying to figure out who gets triplet therapy, NCCN said anyone that you would offer docetaxel to before, now you should offer triplet therapy, and docetaxel and ADT by itself isn't an option. And who they said should be offered that triplet therapy was anyone who qualified for the CHARTED trial, which is discussed in the handout. But that was our first trial looking at docetaxel plus ADT for castrate-sensitive disease. And that was defined as visceral mets, or at least 4 bone mets where one was outside the vertebral column or pelvis. Now, based on some updated survival analysis that have come out, they say you could offer it to anyone, even low-volume disease, as long as they had metachronous metastatic disease. So that means when they were diagnosed, they were metastatic. Patients that had disease and then later progressed and their metastatic disease occurred at different times, those should not be offered triplet therapy. And that's just based on who was enrolled in the trials for triplet therapy. So you can cross that out and just say anyone, high volume disease, yes, low volume disease as long as it was synchronous metastasis. ASCO kind of says the same thing. They basically say anyone with high volume disease that you were going to offer docetaxel to, you should explain the risks and benefits of triplet therapy and consider cost in that discussion. So the first trial we'll talk about is ARASENS. This is ADT plus docetaxel plus darolutamide. It was FDA approved in July 2022. And based on what occurred in the phase 3 trial is that all patients got ADT and docetaxel 6 cycles, so that's our CHARTED regimen. But they added darolutamide, so 1-to-1 randomization, either darolutamide with appropriate dosing or matching placebo. And their primary endpoint was overall survival, and it was statistically significantly improved. Adverse effects were pretty similar, 44 versus 42%, so that's an important thing to look at when we're adding additional therapies, but overall pretty well tolerated. Then we have ADT plus docetaxel plus abiraterone, so this is our Piece 1 trial. It's not quite as pretty and easy to understand as the ARASENS trial. So in this study, they took de novo castrate-sensitive first-line prostate cancer patients and randomized them to one of 4 arms. So bear with me. So they were either randomized to standard of care or standard of care plus radiation or standard of care plus abiraterone or standard of care plus both. What gets tricky is that the standard of care was either ADT or ADT plus docetaxel, and it was up to the prescriber. So really there's kind of 4 different options that we're looking at. So how they interpreted the data and what was published in the Lancet publication was they just looked at if they got abiraterone or not and whether they got docetaxel or not. Both, if they got either of those, both improved PFS and overall survival. And then we looked at different subgroups, and so in those that received docetaxel as part of their standard of care and had abiraterone added, compared to not adding it, overall survival was improved statistically significantly. So that's really the take-home point of why we recommend triplet therapy based on this study is that subgroup analysis. They also delved deeper into high-volume disease versus low-volume disease. At the time of publication, low-volume disease data was not mature, but high-volume disease definitely had a benefit. And you'll note on the previous slide I said only de novo patients, so those would be your metachronous metastatic. They did not allow, that would be your synchronous metastatic. They did not allow metachronous metastatic disease, which is why the NCCN doesn't recommend triplet therapy for those patients. As far as adverse effects, adding abiraterone did not increase your docetaxel adverse effects, but it did add the toxicities we would expect from abiraterone, like hypertension and hepatotoxicity. As a side note, I'd just like to take this time to talk about abiraterone a little bit more. Some of this is for test purposes, and some of this is just for clinical practice if you have patients that are on these drugs. So abiraterone acetate, Zytiga is the brand name. It is now off patent, which means if you have patients who are struggling to pay for a drug, because maybe they're Medicare patients, because a lot of our prostate cancer patients are older and they have a 20% copay, there's no longer free drug programs because it's off patent. But there's another brand product called Yonsa that's micronized abiraterone that is still branded and has free drug programs. It is given, the purpose of the Yonsa is it can be taken with or without food, whereas the abiraterone conventional has to be taken on an empty stomach, which could be an issue for some patients. It's 4 pills on an empty stomach. So that's on your left. And then on the right is the abiraterone acetate micronized that can be taken with or without food. Another thing to note, there was a phase 2 study that looked at doing 250 milligrams with food. So that's 1 tablet with food instead of 4 tablets on an empty stomach. And it wasn't compared head to head, but the survival and PFS they saw in that study was consistent with the 4 pills on an empty stomach. So that's something you can consider as an off-label dosing strategy. And it will be cheaper if patients are paying per tablet. There's some online pharmacies that don't bill insurance, and you can get a 1-month supply of this 1 pill a day for a reasonable copay. Another thing to note, you have to have a corticosteroid when you're using abiraterone. Its mechanism of action is it's a CYP17 inhibitor, so it decreases testosterone production. With that, it causes excess in mineralocorticoid, and that can cause hypertension, hypokalemia, fluid retention, so you need the corticosteroid to decrease that adverse effect. Which one you use depends on which branded product you're using, and what setting of disease, if it's castrate sensitive or castrate resistant. But for testing purposes, I would just make sure if you're picking an option with abiraterone in it, that it has a corticosteroid. Okay. So now we are to castrate-resistant disease. And this is where a lot of updates have been happening in the last year to 2 years. So these are patients who have metastatic disease but have progressed despite testosterone less than 50. And the patient we'll talk about here is GC. So he has metastatic castration-resistant prostate cancer and irritable bowel disease. He was initially treated with leuprolide and apalutamide. When he progressed, they switched him to docetaxel plus ADT. His most recent PSMA PET scan shows numerous sites of progression in the lungs and bones. He's a truck driver and prefers a treatment with the least risk of diarrhea, as it could impact his ability to work. In addition to continuing leuprolide, which is the most appropriate next line of treatment for AB, is it enzalutamide, radium-223, cabazitaxel, or lutetium-177 PSMA. Okay, great. So radium-223 not indicated because he has visceral disease, and that's for bone-only metastases. I don't talk about radium too much in this presentation, but it's in the handout. But make a note to yourself, that's a very testable thing. Survival benefits only for bone-only disease. Cabazitaxel versus lutetium are really your options, and cabazitaxel has more diarrhea, so lutetium is the correct option. Just out of curiosity, how many of you are using lutetium at your practices? Only a couple? Okay. We just started within the last year. So, all right, so let's talk about what the NCCN says for castrate-resistant metastatic prostate cancer. For simplicity purposes, The first section we'll talk about is for those with no homologous recombination repair mutations. We're just going to pretend like they don't exist. And then in a minute, we'll talk about only your options for those patients. So pretending like homologous recombination repair mutations don't exist, if you have castrate-resistant disease, first you're going to always continue your ADT backbone. If they have bone-only metastases, radium-223 is an option with a survival benefit. And beyond that, it just depends on what they had prior. So if in the castrate-sensitive setting all they had was ADT, which fewer and fewer patients are going to meet that criteria, you have 3 options: docetaxel, abiraterone, or enzalutamide. All have a survival benefit. All are Category 1 recommendations. If all they had was a prior novel hormonal therapy, so that's the term we use for abiraterone, enzalutamide, darolutamide, apalutamide, any of those drugs, we're just going to say novel hormonal therapy. So if they have one of those in the castrate-sensitive setting, your choice is docetaxel. If they had only docetaxel in the castrate-sensitive setting, you have either novel hormonal therapy option, enzalutamide or abiraterone, or you have cabazitaxel. And if in the first-line castrate-sensitive setting they had both docetaxel and an oral novel hormonal therapy, then your options are cabazitaxel, lutetium 177 PSMA, if they're PSMA positive, or you can re-challenge with docetaxel if they only had 6 cycles up front and then stopped and didn't progress on it. So cabazitaxel is not new, but I still like to include it in the presentation because you don't see it anywhere else, and because studies come out from time to time looking at sequencing, and it's always kind of involved in those studies, so it stays relevant. Just a quick review of the literature around cabazitaxel. The TROPIC trial is what got it approved compared to mitoxantrone, showed a survival benefit. The issue with the study is that the 30-day mortality was almost 5%, so that's very high. So it's not a well-tolerated drug. The dose in this study was 25 milligrams per meter squared every 3 weeks, and diarrhea and febrile neutropenia were the biggest toxicities. But this is what gained its FDA approval. The Prostate trial, that's listed second, was a non-inferiority study looking at patients who had had prior docetaxel, comparing a lower dosing strategy to the initially approved one, so 20 milligrams per meter squared instead of 25. As I said, it was a non-inferiority study, and it met non-inferiority. So based on this, the FDA updated their recommended dose to 20 milligrams per meter squared. NCCN still lists both as an option, but says reserve the 25 for young, fit patients and add growth factor. The Firstana trial was actually a negative trial, but I like it because of some information it gives us. So this was looking at the first-line setting, so no prior docetaxel, and compared cabazitaxel to docetaxel head-to-head with either dosing strategy with the cabazitaxel. And like I said, it was a negative trial, so they were all equivalent. So it didn't show superiority of cabazitaxel like they were hoping. But what it does tell us is the difference in adverse effects between the drugs, which I like. When I'm counseling a patient who's been on docetaxel, I can tell them kind of what to expect and how cabazitaxel compares to their prior experience. Generally, they're complaining about their neuropathy and they're asking if it's going to get worse. And we can say that the docetaxel causes more neuropathy, so 25% versus 11 to 12 for cabazitaxel, so that makes them feel better sometimes. Febrile neutropenia was a lot lower with the lower 20 milligram per meter squared dose of cabazitaxel compared to either of the other options. And then lutetium 177 PSMA, brand name Pluvicto. This is kind of the newest drug to get approval in this space, and because of the logistics involved in offering it to patients, it's taken longer to be taken up at different practice sites. Like I said, we just got it within the last year. It's a radiopharmaceutical, so typically nuclear medicine or radiation oncology are the ones providing it, not medical oncology. It delivers a beta particle radiation to PSMA-positive cells in the surrounding microenvironment. It's indicated in the castrate-resistant setting with one prior taxane therapy and one prior androgen receptor pathway inhibitor, or one prior novel hormonal therapy. PSMA positivity is determined with a PSMA PET scan, which I'll mention a little bit on the next slides. The dosing is 200 millicurie IV every 6 weeks, up to 6 doses. Toxicities, the big ones, dry mouth, renal toxicity, GI side effects, and myelosuppression. So it's not without toxicity just because it's not a chemotherapy. Pearls, patients have to follow precautions with close contacts for 3 to 7 days. So can't be within 3 feet of household contacts, can't share a bed, and it's longer for pregnant women and children. It does need an antiemetic pre-medication. You dose reduce for dry mouth, GI toxicity, renal toxicity, and myelosuppression. So what is PSMA? It's a transmembrane glutamate carboxypeptidase that's overexpressed in prostate cancer. More than 90% of metastatic castrate-resistant prostate cancer patients will be positive. So this is a common thing to be PSMA positive. Its expression correlates with the poorer prognosis and more aggressive disease, and it's upregulated by androgen deprivation. So it's something that can develop while they're on treatment. So just because they're not PSMA positive at the beginning doesn't mean they won't be by the time they meet this castrate-resistant point in their treatment. PSMA is also expressed on normal prostate cells, the small intestine, proximal renal tubules, and salivary glands. I like that because it makes sense. It matches the toxicities that you see. It's easy to remember. PSMA PET imaging, there are 3 different FDA-approved products for the PET imaging, and it can be any of those. There's not one that's required to use this drug. So any PSMA positive PET scan qualifies them for use of the drug. The VISION trial is what got this drug approved. So this is its phase 3 trial. It had 831 patients with metastatic castrate-resistant disease, prior treatment with a taxane, and at least 1 novel hormonal therapy. In the trial, 40% had 2 novel hormonal therapies, so you would assume both mechanisms of action. And they did have to have the positive PSMA PET scan. They were randomized 1-to-1 to Lu-PSMA or standard of care. Their standard of care was defined as ADT, good, everyone should be on ADT, bone-directed therapy, which that's good, and then novel hormonal therapy. As I mentioned, 40% had been on 2, so I do question if these standard of care patients were on an active treatment, and they didn't allow cabazitaxel in the standard of care, which would be your alternative therapy. So just some things to keep in mind. Regardless, median overall survival was met 4 months longer with lutetium PSMA. Progression-free survival was also improved. Adverse effects were higher, so your grade 3-4 adverse effects, 52%. The ones that were more than 30% all grade were fatigue, dry mouth, nausea, and anemia. So things we would expect based on its mechanism of action. So those are our 2 kind of options that we hadn't talked about yet, but how do we know which one to use? It's a great question. There's not a lot of guidance available on sequencing therapies. NCCN just says we can't tell you what to do in what order. Some things that they say to consider is the use of ARV7 testing, which is a mutation that can lead to cross-resistance between your novel hormonal therapies. So if they're positive for ARV7, you probably shouldn't do another hormonal therapy after they've progressed on one. Initial incidence of ARV7 at diagnosis is like 3%, but after treatment it can increase to 20 to 40%. The problem is it takes a while to get this test back, and at our practice, our doctors would rather just start them on the other oral and see if they progress or not, because by the time you wait for the testing to get back, it could take just as long. I think this could definitely change in the future. Has anyone used this test, ARV7 testing? So I think it's more of a theoretical thing at this point, not happening as much in clinical practice. And then the other question is, when do we use cabazitaxel? So there's a couple of trials we can look at to help us decide. One is the CARD trial. So this looked at metastatic castrate-resistant patients who had been treated with docetaxel and one novel hormonal therapy, either abiraterone or enzalutamide. And they were randomized 1-to-1 to either cabazitaxel or the provider's choice, which would be the other novel hormonal therapy, so whichever one they didn't have first. Because in practice, once patients progress on one oral therapy, they want to just go on the other oral therapy. They don't want to go on chemo. They're older, they don't want to do chemo. There's an oral option, why would they do that? So this is kind of testing exactly what's happening in clinical practice, this decision we have to make. And what they found was the patients that got cabazitaxel instead of the other oral had a longer progression-free survival and overall survival and PSA response. Statistically significant for all endpoints. So really, if the patient wants the best, most effective treatment, instead of just going to the other oral, they should go to cabazitaxel. But now we have Lu-PSMA in the mix, so how do we decide between Lu-PSMA and cabazitaxel? Well, the phase 2 trial for Lu-PSMA was actually compared it to cabazitaxel, so it's useful in kind of helping make that decision. So patients in this study had had prior docetaxel, and that was required, and then 90% also had a prior oral novel hormonal therapy. Randomized 1-to-1 to cabazitaxel, that lower 20 milligrams per meter squared dose. And then the other arm was the Lu-PSMA with the same, similar dosing that we talked about before, every 6 weeks. They did some dose finding in the study as well. The primary endpoint was decrease in PSA by 50%, which was higher in the Lu-PSMA arm, but when you look at survival or progression-free survival, there was no difference. It didn't reach significance. So based on that, you just kind of have to look at toxicities and which one was better tolerated. And the survival curves crossed at 6 months in the study, so it really looks like there's probably not a difference. So as far as toxicities, Lu-PSMA has more dry mouth, dry eyes, and thrombocytopenia, whereas cabazitaxel has more diarrhea, neuropathy, and febrile neutropenia. Right, there's several other options discussed in the guidelines in this castrate-resistant setting. I'm not going to go through all of them. They are discussed extensively. All the studies are in the handout. I just wanted to highlight a couple. Cabazitaxel plus carboplatin is an option for aggressive patients, and how they defined aggressive is very complicated. But it's based on their molecular signature or their the genetics of the cancer, or some clinical features like how high their PSA is and the volume of disease. So for specific young fit patients with aggressive disease, you could consider that combination regimen. Abiraterone plus dexamethasone is an option for people who have PSA progression only on abiraterone plus prednisone. So their disease isn't progressing, they're not symptomatic on imaging. Their disease is not progressing on imaging, and they're not symptomatic, but PSA is going up. There's some data to support switching their corticosteroid to dexamethasone. Sipuleucel T is discussed in the handout, not something we do in clinical practice. Pembrolizumab is an option. It's a 2B recommendation in NCCN if they meet any of those criteria. I very rarely see any patients meet those criteria. It's not something we use a lot in prostate cancer. That brings us to our next audience response question. RC is a 65-year-old male with metastatic prostate cancer. His tumor mutation testing revealed a PALB2 mutation. He was diagnosed 2 years ago and initially treated with leuprolide and docetaxel for 6 cycles. He was maintained on leuprolide since completing docetaxel. Most recent labs show PSA was increasing, and imaging showed several new skeletal mets. ECOG is 1, in addition to continuing ADT, which is the following is the most appropriate at this time. Is it olaparib plus abiraterone, rucaparib, niraparib plus abiraterone, or talazoparib, or enzalutamide plus enzalutamide? Sorry. Okay, not as many people want to play this time. You can tell we're going to talk about PARP inhibitors next. You all picked olaparib plus abiraterone. So, an easy way to get this question right on an exam, talazoparib is the only one that's approved for all homologous recombination repair mutations. The others are only approved for BRCA mutations. The combination regimens are only approved for BRCA mutations, whereas talazoparib combination is approved for all homologous recombination repair mutations. So that would have been the correct answer because they had a PALB2 mutation. Okay, so briefly we'll talk about prostate cancer genetics before we get into all of our PARP inhibitor studies. So that's what's new and happening in the prostate world right now. So for metastatic castrate-resistant prostate cancer, genetic testing is super important. It really affects their treatment options. Homologous recombination repair mutations can be as high as 33% in this setting. The list of different HRRM mutations is listed, but BRCA and ATM are BRCA2 and ATM are your two most common. You should consider retesting at the time of progression because these are mutations that can develop while they're on treatment. The gold standard is tissue testing to look for these mutations. There is ctDNA, which is a liquid blood test that can look for these mutations. However, you should use caution with this option because there can be false negatives and false positives. So false negatives could occur if you catch a clone in the blood that's not actually what's driving the cancer. So some indeterminate potential clone floating in the blood, you grab that, you see that, you mark them as positive for a mutation when they're not. Or you can have false negatives if there's not enough circulating tumor DNA, so it's going to miss that mutation. So it's an option, but it's not the best option. And when we look at the trials of PARP inhibitors, it's important to note how they defined their mutation status. While we're talking about genetics, just a note on DMMR, that can occur in 3 to 5% of patients, and then they would be a candidate for a PD-L1 therapy like pembrolizumab. So who should get genetic testing? A lot of people with prostate cancer. So the mutations that should be checked per NCCN are listed, but for germline testing, anyone with high risk and above prostate cancer, so high risk, very high risk, N1 or M1, should all have genetic germline testing. Also, if they have specific family history or personal history. Somatic or tumor testing should be done on anyone with metastatic prostate cancer, and you can consider it with regional disease. Like I said, you might have to do it again at the time of progression, but at the very least should be checked for metastatic patients. So this is, as promised, the other half of that chart that I showed you earlier that includes your options for patients with homologous recombination repair mutations. So if all that they have had prior is ADT, then you have 3 combination options. As I said earlier, not a lot of people are going to meet this criteria by the time they get to castrate-resistant disease because they've had something else up front. But due to the way that the studies were designed and the time that these combination studies were taking place, that's who was in the studies, is people that only had ADT first. So that's where the combination regimens have a Category 1 recommendation. And again, just to note, talazoparib is for all homologous recombination repair mutations. The other combinations are for BRCA only. If they've had prior novel hormonal therapy, the options are a little different, and they've actually changed with the NCCN update this week. So take out your pen, and you're going to want to change. Rucaparib is now Category 1. It had a Phase 3 Triton trial that came out that showed an overall survival benefit for BRCA mutated patients. So it's now Category 1. I don't have that study in the slides, unfortunately, but it isn't a single agent option if they've had either abiraterone or enzalutamide treatment already. And then olaparib change, it is Category 1 for BRCA mutated only. For the other non-BRCA mutations, it's a Category 2A recommendation. Your combination regimens have lower level of evidence here, again, just based on who was included in the trials. And your olaparib plus abiraterone is not an option because there weren't patients with prior novel hormonal therapy in that trial. If they've had prior docetaxel only, you still have all 3 combination regimens, just a lower level of evidence. And if they've had prior novel hormonal therapy and docetaxel, your combination regimens are not recommended, and just a single agent PARP inhibitor is what's recommended. So the PROFOUND trial was your olaparib single agent trial for patients with homologous recombination repair mutations. At this point, it's kind of old, but I like to leave it because it demonstrates the heterogeneity of these homologous recombination repair mutations. So it was a phase 3 trial with 387 patients with castrate-resistant metastatic disease who had progressed on 1 novel hormonal therapy. They were randomized 2-to-1 to either olaparib or the physician's choice of one of the novel hormonal therapies. There were 2 cohorts. So cohort A is BRCA1, BRCA2, and ATM, and cohort B is all the other mutations, which are listed at the bottom. Just some things to note, most patients had had a prior taxane, and about 20% had both novel hormonal therapies before, which makes you question the efficacy of the comparator arm. Then when we look at efficacy, progression-free survival that was imaging-based, a clear benefit for cohort A, which is your BRCA1, BRCA2, and ATM patients. When you combine it with all the other patients, there's still a benefit, but leaves you to question if you looked at just cohort B by itself, would there be a benefit? Well, and then if you look at specifically the PPP2R2A mutation, there was definitely no benefit. It was actually negative, so the hazard ratio was 5, so it increased the risk of death if you used a PARP inhibitor. So all of the homologous recombination repair mutations are not created equally, and you should not use it for that specific mutation. An overall survival update came out in 2020 that clearly showed the benefit for BRCA1 and BRCA2. The cohort B, so all other mutations, did not have statistical significance. Even when they excluded that specific mutation, there was still not statistical significance. So that's why there's a lower level of evidence in the NCCN guidelines for the other mutations, but it is still FDA approved for any mutation, just wouldn't use it with the PPP2R2A. So then we get into the combination therapies, and again, this is where all the new indications were coming out in the last year. We had 3 combination drugs combination regimens that came out. 2 were in combination with abiraterone, and 1 was with enzalutamide. Some things to note about our PARP inhibitors. Talazoparib is the most potent of the 3, so we're going to expect the most toxicity from that one, whereas olaparib and niraparib are pretty similar. And then the indication for talazoparib is also different, as I've said multiple times. When we look at the studies, the first one we'll talk about is talazoparib, ADT, and enzalutamide, because that's the one that's the most different. This was TALAPRO-2. It was a phase 3 trial. They were going for an indication that included all homologous recombination repair status, so mutated or not. So every patient they were looking at. And that was cohort 1. Cohort 2 was only those with the homologous recombination repair mutation, and that cohort is still ongoing. These patients had no prior treatment in the castrate-resistant setting. Everybody got ADT and enzalutamide, and then they were randomized to adding a PARP inhibitor with talazoparib or placebo. Of note, they used a dose of 0.5 milligrams. The standard dose in breast cancer is 1 milligram, which was used in earlier trials and showed significant toxicity. That was dose limiting, so they went with a lower dose. In this study, they were prospectively tested for their mutation status, and tumor tissue was required. So they're doing kind of the gold standard, prospective categorization and tissue testing. 14% had additional ctDNA testing. The prior treatment, abiraterone and docetaxel were both allowed, but numbers were very low because of the time when the study was done. The standard of care was ADT alone. So you really have to dig into the efficacy endpoints to find out what you're looking for. But if you look at all patients, regardless, and this is in cohort 1, regardless of mutation status, there was a statistically significant benefit. But if you look a little deeper at only your patients with a mutation, which was only 169 patients, that seems to be really driving the efficacy. So the hazard ratio is much smaller for those patients. And then if you skip over to our blue boxes and you look at just your BRCA mutations, that's really, really driving the benefit. So your hazard ratio is even smaller, 0.23. Your non-BRCA homologous recombination repair mutations didn't meet statistical significance. We'll look more at that subgroup on the next slide. But overall survival was also not mature at the time of this initial reporting. So then we look at only your homologous recombination repair patients, so the ones from cohort 1, as well as those that have been enrolled so far from cohort 2, to give you a higher patient population number to look at. And with patients with a mutation, there was a statistically significant PFS benefit. And then there was a benefit seen in BRCA and non-BRCA mutations. This is just an interim report, so not powered, didn't meet statistical significance, but based on this and the rigor of the mutation status testing, the FDA approved for all homologous recombination repair mutations. Safety, as expected, there's a lot of side effects with this regimen. So grade 3 or 4 events were seen in 72% of patients. Somewhere around 70% had to have treatment held at some point for toxicity, mainly due to anemia. So 65% had anemia in the talazoparib arm. About half had to have their dose reduced, and 20% had to stop the talazoparib due to toxicity. MDS is always important to look at with your PARP inhibitors. Only 2 patients had MDS in this study, and pulmonary embolism was a little higher in the talazoparib arm. Then we look at ADT plus olaparib and abiraterone. So this was all patients with a mutation. All patients regardless of mutation status, similar to the prior study, but they retrospectively assigned mutation status, and a third had only ctDNA testing. So their testing was not as rigorous, and their risk of misclassification bias was higher. No patients had prior novel hormonal therapy in the study, which impacts how it was listed in the guidelines. When you look at survival benefit, I'm just going to kind of cut to the chase. When you look all the way on the right, BRCA mutation, there's clearly a survival benefit that seems to be driving the whole group. And we have overall survival update for these patients. So on the far right, BRCA mutation, definitely a survival benefit that seems to be driving the efficacy. And so that is how the FDA approved it, only for BRCA mutated patients. Safety, pulmonary embolism was higher, so that's just something to note, 6.5%. But the anemia was much more tolerable. Only 15% had grade 3 or higher, and only 8% discontinued to adverse events, which was similar to the placebo arm. Magnitude trial looked at ADT plus niraparib plus abiraterone, and this one was designed very differently from the others. So we only have published data for mutated patients. So there was a cohort that they were looking at for non-mutated patients, and that was closed early for futility. So this study is just homologous recombination repair mutated patients. They did pre-enrollment testing on tumor tissue and blood, so they had good rigorous tumor testing to look at mutation status. They did allow more prior therapies. They could have abiraterone if they didn't progress on it, and about 20% had prior docetaxel. When you look at this one, the results make a lot more sense and match the FDA approval. So BRCA mutated had a statistically significant benefit for PFS, whereas non-BRCA mutated, your other mutations, did not have a benefit. So that one makes perfect sense. It's approved for that subtype only. As far as safety, again, more well tolerated than talazoparib. Anemia is 28%, also saw hypertension, constipation, and thrombocytopenia. That leads us to supportive care and survivorship, which we just have a couple of slides on, but we do have one more question. So LL has prostate cancer that progressed during adjuvant ADT. His PSA increased, testosterone remained below 50, but his scans showed new skeletal metastases. His oncologist wants to add enzalutamide to his ADT, but asks if there's any supportive care medications you would recommend. So which would be appropriate to initiate? Denosumab 120 every 4 weeks, calcium plus vitamin D, alendronate 70 milligrams every 4 weeks plus calcium and vitamin D, or denosumab 120 every 4 weeks plus calcium and vitamin D. Great job. Yes, he needs calcium, vitamin D, and a bone-directed therapy to prevent skeletal-related events. All right, so for supportive care and survivorship, there are a lot of things we have to consider. These patients live for a long time with prostate cancer. It's almost like we're managing a chronic disease state, so we have to consider other parts of their care. For the purposes of this presentation, we're mainly going to focus on the bone-related things, but there is other supportive care topics covered in the handout. Osteoporosis is important because these are older men that get prostate cancer, but also the treatments that we're giving them increase the risk of osteoporosis. So ADT increases the risk and is associated with a 21 to 54% increase in fracture risk. So it's important that we're managing that. These patients also have bone metastasis and bone pain, which can significantly impair their quality of life, so we have to manage that as well. Sexual and urinary dysfunction are discussed in the handout, and then diabetes and heart disease. We've kind of touched on cardiac adverse events throughout, but ADT can definitely cause lots of physiologic changes that increase these risks, so changes in fat mass, lean muscle mass, increased cholesterol and triglycerides, and decreased insulin sensitivity. So it's important that we're managing their overall health as well, or referring them to a PCP to manage these things. Osteoporosis and ADT, all of our patients on ADT should be on calcium and vitamin D with appropriate dosing. We want to assess their fracture risk either with the use of FRAX or doing a baseline DEXA scan if they're at increased risk. If they meet criteria based on their fracture probability, then you should initiate either alendronate, zoledronic acid yearly, so that's the Reclass brand, or denosumab 60 milligrams every 6 months, which is the Prolia brand. For bone metastases, this is a very common complication of prostate cancer, and we want to prevent the skeletal-related events. We do this with our anti-resorptive therapies. Some things that are different about prostate cancer than all the other cancers. So usually you see cancer, you see bone mets, you think we need to add a bisphosphonate or other anti-resorptive therapy. In prostate cancer, the benefit has only been seen in castrate-resistant disease. So if they're still castrate-sensitive, there has not been demonstrated a clear benefit to adding an anti-resorptive therapy. Things that have been studied, castrate-sensitive disease, no benefit. Also, they've studied patients that aren't metastatic and don't have bone mets, but they're just at high risk of developing bone mets to see if they could delay the onset, and there was no benefit there either. So your anti-resorptive therapies like denosumab or a bisphosphonate only for castrate-resistant metastatic disease. Of note, denosumab and zoledronic acid have been studied and compared, and denosumab did meet superiority for prevention of skeletal-related events. So that's a testable question for sure. Denosumab did show superiority for prevention of skeletal-related events. You can also consider radiating bone mets if they have painful bone mets. In summary, most patients diagnosed live a long time with prostate cancer. 99% survive 5 years. The treatment is very, very, very individualized depending on their risk of recurrence as well as patient-specific factors and life expectancy. We've talked through different local therapies and different modalities of systemic therapy. And the treatment landscape is rapidly evolving. Systemic therapies are moving earlier in the course of treatment and extending survival, and treatment is becoming more individualized based on cancer characteristics. So I would not recommend giving a talk on prostate cancer because the guidelines are going to change every time you give a talk the week of the talk because it's always changing. Thank you.